This is a Frontline Club event recorded on the 28th of May 2020. The Mother of All Pandemics, a discussion with Laura Spinney and David Heyman.
Well, good afternoon, everybody, and welcome back for some of you to the Frontline Club series of events that we're now holding by Zoom and online until we can get back to the club. This is, as many of you know, something that normally happens in the flesh. I'm Elizabeth Palmer. I'm a correspondent for CBS News, and I am the moderator today. I'd like to introduce our two guests. Returning to our screen is David Heyman, CVE. He's currently Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine, a man who knows a thing or two about infectious disease and epidemics. He's had several very senior positions with the World Health Organization, among them leading the effort to eradicate polio and also respond to AIDS. From 1998 to 2003, he was the executive director of the WHO Communicable Diseases Cluster and headed then the global response to SARS. He joins us today from just outside Geneva. David, welcome.
Thank you, Elizabeth.
Laura Spinney is our other guest. She's a respected science journalist and also a novelist. She's written for The Economist, Nature, and New Scientist, to name a few publications, and she is also the author of Pale Rider, the Spanish flu of 1918 and how it changed the world. And she joins us this afternoon from Paris. Welcome to you. Welcome to all our listeners who are joining us from around the world. And let me remind you that at the bottom of your Zoom screen, there is a place where you can type a question. I will check those questions regularly and put them to our guests. There's also an option to raise your hand, which means you can ask your question yourself. And if that happens, I'll come to you, I'll say your name, and then you can speak up. But I'm going to begin with a question to Laura. You wrote this book on the Spanish flu 3 years ago. So I have to ask you, did you know something we didn't?
No, absolutely not. Although, people like David who work in this area have been warning about another pandemic for a very long time. And, we may not be able to predict when or how bad or what the actual pathogen is that would cause the pandemic, but it's not that surprising that they happen from time to time. There have been 15 flu pandemics, for example, in the last 500 years.
Was the Spanish flu epidemic the largest pandemic in history?
Probably not. Probably the Black Death was worse, but the means of measuring cases and deaths in that pandemic were even vaguer than they were in 1918. So it's a little difficult to make the comparisons, and they're also being updated all the time. But it was certainly the worst pandemic and probably the worst catastrophe in terms of sheer loss of human life in modern history.
Give us some idea of the scale of it, and I'll ask David to weigh in too. But I'd like to hear about how the current COVID-19 pandemic compares. It feels huge to us, all those millions of us in lockdown, but I think that history shows that 1918 was far worse.
Yeah, so 1918 on current estimates, the flu infected 500 million people. That would have been 1 in 3 people on Earth at the time, and killed an estimated 50 to 100 million of them. So that equates to 2.5 to 5% of the global population at that time. And just to put those numbers in perspective, the First World War, with which it overlapped, killed an estimated 18 million people, and the Second World War about 50. It probably killed more than either of those, and possibly more than both put together.
Why? Why was it so lethal?
I think we don't know is the short answer, and it's still very much an open question. But what we do know is that there were probably several factors that made it so bad. So there's quite a lot of evidence, for example, that the flu strain that caused it was particularly virulent itself, inherently virulent. And then probably the state of the world exacerbated in many ways. You know, the world was at war. A lot of people were on the move. A lot of people were hungry, and that compromises the immune system. A lot of people were stressed. Doctors were at the front. Healthcare systems were disrupted. There are many reasons why the state of the world at that time probably exacerbated it.
I was looking at some old film footage, black and white film footage, yesterday, and you see a lot of ships, overcrowded ships of immigrants, I suppose, certainly ships of troops. Was that a major vector for this disease, that great boatloads of people were sailing around the world, and when they got off, if they weren't dead, they were spreading the flu?
Yes, I mean, by ship was probably one of the main ways that the flu was transported around the world at that time. They didn't have commercial air flight. And Woodrow Wilson, the president of the US at the time, famously ignored his senior military doctors and listened preferentially to his senior generals and ordered the transports to continue, despite the fact that the flu was already raging. Considered that the war was a greater priority, and so there were terrible scenes on those ships. And yes, as you suggest, they basically brought the flu backwards and forwards across the Atlantic.
David, can you draw some parallels or point out the lack of parallels, perhaps, between 1918 and what we're living through today?
Thanks, Elizabeth. Yeah, and thanks, Laura, for that explanation. I would just add to that explanation one other thing from a biomedical point of view, and that is that when influenza occurs, the cells in the respiratory system are the target. And so the virus reproduces in those cells, and it bursts those cells open when it escapes from the cells. And as a result, people are very susceptible to bacterial infections on top of their influenza. And if you think back to the early 20th century, there were no antibiotics there. And so these people couldn't be treated as they can be treated now in flu and also with COVID, to treat those bacterial infections on top of the viral infections. So we're actually better armed today than we were back then to deal with influenza and also with infections like COVID.
So did people in 1918 die essentially of some kind of pneumonia or massive inflammatory reaction, just as COVID patients are dying today?
It seems so, according to what's understood about the virus, as Laura said earlier, that this virus was a very virulent virus. And much like the virus today that causes COVID, this virus caused a harsh immune reaction in some people, it's thought. But it's difficult to go back and see for sure. There are some tissue specimens from people who were sick during the time that have been examined, and it's been concluded that this was quite a virulent virus and may have caused what COVID is doing today, that severe immune response many times after a person appears to be getting well.
Now, Laura, that virus, and I know this, full disclosure, because you and I spoke last week, and I learned from you that the virus mutated. So there was a first wave, and then there was a much more lethal second wave. What happened?
So this is one theory, but there is some evidence to support it from Jeffrey Taubenberger's group at the NIH. Basically, the theory goes like this, and it's based on their comparison of the sequences of the virus that caused the first wave and the strain that caused the first wave and the strain that caused the second wave. And the idea is that the pandemic strain emerged in the latter months of 1917 or the early months of 1918, but it wasn't to begin with very transmissible, not very contagious. And so it emerged not very easily through a background of seasonal flu. And then in the late spring, the idea is that it mutated to become more transmissible, to become more contagious. And so when it erupted in August, it was pure pandemic strain and it was highly contagious. And that was definitely the most lethal wave. The vast majority of those 50 million deaths estimated, we think occurred in the 13 weeks between the middle of September and the middle of December 1918. So though it went on altogether for sort of 3 years-ish, the core of it was in the blink of an eye.
David, what are we seeing about this COVID-19 virus's ability to mutate?
Well, there's a great database which collects all the genetic sequence information that's provided by countries. And that database has shown that this virus does mutate, but not quite as rapidly or as easily as does the influenza virus, for example. So it's relatively stable. And in looking at these various mutations that are occurring, there have been attempts to link that with how this virus behaves in humans, but there hasn't been any indication that this is either becoming more virulent or less virulent or more easily transmitted or less easy transmitted. What we do know is that it doesn't transmit like influenza. This virus causes outbreaks which can be stopped, which can be contained, and therefore you can interrupt transmission of a whole series of people who might be infected from contacts. So countries like Germany and the countries in Asia that have continued to do contact tracing, identifying people who were contacts who were sick and isolating them, are much ahead today in control in keeping the reproductive number down, that is, the number of people infected down, based on their strategy.
But doesn't that leave them in a position where they're just having to play whack-a-mole for a long time, that until there's a vaccine or a treatment, we're all going to be ducking and covering from this thing for, could be years and years?
Well, what's good about this virus, if there's anything good, is that we know its targets. We know that it targets the elderly and those with comorbidities, and we know that health workers are at risk. So those three populations need to clearly understand how to protect themselves, and governments need to facilitate that in ways that they can do it. But Elizabeth, it's not good to say until a vaccine, because we don't even know if there can be a vaccine. So it's really, governments have locked down in many countries saying, we'll wait until we can get the reproductive number low, and then we'll have a vaccine in the future. But there's no certainty that there will be a vaccine. So we have to use the tools we have today to make sure that we can do the best.
But doesn't that, or does that imply that we're looking at a situation where anybody over 70 can't get within 2 meters of another human being for the rest of their lives?
Well, at present, what's being done is there are countries like Gibraltar which have the golden hour, where the elderly are permitted to go out to parks and encouraged to go out to parks and do their shopping, and others stay away from them. They physically distance. That's a temporary measure. There need to be long-term measures that are put in place. And the human being is a good innovator, and there will be innovative ways that we can make sure that the risk populations are protected. And in addition, there may be some drugs or antibody preparations that are also useful in treating or even preventing infection in the future. So I count a lot on human innovation to be able to deal with this, and I'm not so sure we need to wait for a vaccine, which may be years in advance or never.
Laura, why did the flu in 1918 fizzle out? What happened to it?
This is kind of the path that pandemics take eventually, even if you don't intervene in them. They either kill off their victims, or their victims recover and become immune to them. And so the flu, the pandemic strain, gradually recedes, or it mutates to become a more benign form through natural selection. And then you get, so for example, every seasonal flu that circulates in the human population started as a pandemic strain and then became more benign. So that's what tends to happen. And
so there's no reason to think that won't happen with this? Or is it just a different beast?
With this, I don't know what David would say about that, but I think that is one of the more optimistic scenarios with this. It could disappear altogether, but from what I understand, it's more likely that it becomes a kind of seasonally circulating disease that is in a kind of endemic equilibrium with us, like flu.
But in as lethal a form, so older people remain as vulnerable, or is it pretty much destined to get weaker?
But again, David probably be better to speak to this than me, but if you think about seasonal flu, it kills 40,000 people in Europe every year. So it's benign, more benign than a pandemic strain, but not that benign.
David, you want to add on to that?
Yeah, well, there are 4 coronaviruses that circulate in humans. They're endemic in humans. They've all come from the animal kingdom. As Laura said, all our infectious diseases obviously came at one time or another from the animal kingdom and are now endemic in humans. So these 4 coronaviruses sneaked into human populations, spread around the world, and are causing common cold each year. So we know that coronaviruses can become endemic in human populations. This virus, though, we don't yet know its destiny. And as Laura said, it could just disappear, as many pandemic viruses do, or it could remain with us as a permanent inhabitant. That was the concern with SARS, and that's why there was such a rapid and global response to try to stop it from becoming endemic if it would.
And what happened to SARS? Where is it?
SARS is gone. It remains in a few laboratories, but it was a one-time mutation, either in an animal or a human, and then it spread quite easily to many different countries. And by a global effort, which is not happening as well this time as it did then, the outbreak was contained and it stopped. But this was a different virus also. It grew lower in the respiratory system than this virus, which is upper respiratory, which transmits much easier.
But in essence, in the case of SARS, every person who had it was confined, and ultimately the disease failed to spread because nobody who had it was in contact with anybody else. It was like a hard stop. Is that right?
That's right. It was a hard stop. It wasn't what people call herd immunity, which meant that so many people became infected and immune that it couldn't transmit. This was just a hard stop. And the Chinese, when they began with this new outbreak, began in the same way to see if there could be a hard stop of this virus. The problem is that it had already spread quite extensively throughout the world by then.
Yeah. So we're well past that possibility. We have to hope for one of the other alternatives. So let's talk a little bit about the origin of the pathogens or these pandemics. And I'd like you, Laura, to talk about something that you go into extensively in the book. Absolutely fascinating. All the work and the research that's gone into try and find patient zero of the 2018 pandemic. Where did that virus come from, and who was the first person to get it? We want names, phone numbers.
Yeah, no, we don't know. The only thing we know for sure is that it wasn't Spanish.
Well, let's stop right there. Can you just explain why it's called the Spanish flu?
Yeah, I mean, it's, a lot of people know this story, but I think it's important to tell it, first of all, because of how unfair it was that it was called Spanish, but also because it shows how political a pandemic is, and we're seeing that again today. So the reason it's called Spanish is that it erupted while there was a war on, and it was in the States, France, Britain, perhaps also some of the Axis countries before it was in Spain, but those countries being at war censored their press, kept that information out of the newspapers, supposedly so as not to lower the morale of their populations. And Spain, being neutral, reported on its first cases in May of 1918, and those cases included the king, Alfonso XIII, so he made it very visible. He went on to recover, by the way. And so the Spanish newspapers reported on it, and the health commissioner, I think that was his title, anyway, the person in charge of public health in Spain at the time, was able to stand up in front of the Royal Academy of Medicine in Madrid on the 29th of June, as late as that, so many months after the first cases had been recorded, and say that he had no information about cases anywhere else in the world. So he himself thought it was coming from Spain. As I said, it had been in other countries.
No kidding. Yeah, so there was just no communication, or very little.
Well, so at the beginning it was censored, and everybody thought, including the Spanish, that it was rippling out from Madrid. And then when people saw how serious it was, and as the war ended, more information started to come out.
So let's get back to patient zero.
So it wasn't Spain. There are 3 theories today as to where it started, and they correspond to origins in Shaanxi, which is an interior state in China on the border with Inner Mongolia, to Kansas in the United States, not far from the military base Camp Funston, where the first cases were officially recorded, and to a British military base in northern France at a place called Etaples, just south of Boulogne-sur-Mer, Yeah, so those are the three possibilities. And today, as I speak, we can't choose between them, although there is live research going on into this. And some test tubes came to light the other day with samples of lung tissue from an earlier outbreak of respiratory disease at the British military base I mentioned in France, which I think are being analysed right now, and they might actually shed some more light on this question. So it's not impossible that we could have an answer to it, but we don't yet.
But if you go back before patient zero, there has to be an animal, correct? Is that true for the Spanish?
Patient zero is the first human to have caught the disease.
So what animal gave us the 1918 flu?
So it would originally come from a bird, and birds are, especially water birds, are considered the sort of natural reservoir for influenza. But it could have come via an intermediate host, rather like we're suggesting the COVID-19 virus did. There's some suggestions it was a pig. And as far as I know, we can't determine today whether it came directly from a bird or via a pig. But analysis of its sequence suggests that it was very avian. It was very like an avian flu. It hadn't changed that much.
David, how does COVID-19, are you convinced that there's overwhelming evidence that it came from a bat and it came from somewhere in or around Wuhan?
Well, what the genetic sequences show, and that means tracing back, knowing the regularity with which this virus mutates, tracing backwards to a full sequence. And if you trace backwards, you come to a period in late October or early November where the virus would have been identical or almost identical to a virus that's carried by bats. So it's assumed that this virus has come from bats, either directly to a human or indirectly to a human through an animal. Now, the live animal market in Wuhan in the mid-December period was the source of a massive outbreak, but not necessarily the first outbreak. So it may be that there were animals that were infected in one market, moved to another, or somehow. So this virus may have emerged several different times into human populations in November and then in December, but it's no longer emerging into human populations. That's fairly certain now within China. So it was a one-time or a several-time event, and now it's one that's a human virus and transmitting in humans, and we'll see what its destiny is. You know, you were talking about this projection of maybe there'll be a wave coming up. Those projections are purely based on epidemiological modeling, which is not truth. It's only showing worst case and best case scenarios based on assumptions that the modelers make. So they can say all they want about what they think might happen, and that's good for public health planning, but we just don't know what the destiny is.
I've got a couple of questions I'd like to get to here, but let me ask you as a follow-up briefly, do you think we'll ever find patient zero for COVID-19? And is it important to find that person?
What's important now is to understand the risks that are occurring in China that permit these emergence of infectious diseases to leave the animal kingdom and come to humans. There are many theories about this, and now it's time to really look. After the SARS outbreak, there was an attempt to identify whether or not market handlers in live animal markets were more infected with the virus than in the general population. Those studies began, they showed that there were a certain percentage of market workers that were infected or that had antibody to a coronavirus, but then they weren't continued to compare to the general population to see if this was actually this coronavirus or another coronavirus. And those studies lost funding and didn't continue, which is always a problem after outbreaks, Elizabeth. When they're over, the money dries up. And so now is the time to really go in and understand what's going on. And I know the Chinese are very interested in doing this through the Chinese CDC and others. And I'm sure that this will happen now as time goes on.
I see the Americans yesterday, overnight, I think it was the National Institutes of Health said, we're actually holding open the possibility that this virus escaped from the Wuhan lab, that it wasn't a spontaneous coming out of an animal into the human population in a market. Is that politics or is that science?
What I would say is show me the evidence. And if there's evidence, then we have to believe it. But I haven't seen any evidence that makes me believe that this is anything more than a naturally occurring emergence, because they occur regularly. Ebola occurs regularly, as you know, and other viruses. And so until I see the evidence, I will believe that this has come from nature into humans. Laura may have a different view, but that's my view.
No, I thought there was a paper that showed that it that seemed to suggest that it was natural evolution, comparing it to other bat viruses, wasn't there, David?
There was, in tracing backwards, yeah.
So it's not definitive, but it's looking like it was natural at this point in time.
Yeah. I've got a question here from Sebastian Noakes. I think this falls to you, David, but feel free to weigh in, Laura. How important is antibody testing? We've just seen the UK government discourage people from using at least one of the antibody tests because it's not accurate. And yet he points out the test for AIDS isn't 100% accurate. Would antibody testing, especially if it were widespread, help in this instance, and how?
Well, first off, there are many, many antibody tests. There are some that are rapid tests, which can be used by an individual, and there are some that have to be used in the laboratory. And then there's the standard, which is a neutralizing antibody test, which looks for antibody and shows in the laboratory that this can neutralize the virus. The UK has now validated one of the commercially available antibody tests, but it still must be used in the laboratory. There are no validated rapid diagnostic tests to be used by people. Would this be useful to know your antibody status? Well, yes, it would be useful to know if that test is sensitive enough to pick up all antibody that you've been infected. But we don't understand whether that antibody and other mechanisms in the body have protected against reinfection or not. We don't know that immune passports, for example, would be useful at this point in time. We know that other coronaviruses cause antibody, and those antibodies are protective for maybe up to 6 months, but then you can be reinfected with the same virus. So we're just early in understanding this, but antibody studies are useful, and the UK has been using them to see where there has been transmission of the virus and where it might be more safe than in other parts to unlock first. So yes, there is a great need for these antibody tests, but they're not useful at present in the hands of the population.
And when are we going to know when, if the antibodies confer real immunity and for how long?
Well, all the vaccine research that's going on will give us some indication of that, whether or not these vaccines protect against infection. But there are also animal studies going on, many animal studies in macaque monkeys, that will begin to help us understand, at least in the animal kingdom, what the immune response does. So you can't extrapolate, but you can begin to get experience with that antibody and then study in humans. But the only real way is to wait, tincture of time, wait until the time has passed and we understand what exactly is happening in infected people who recover.
But we're also impatient.
And rightfully so.
Laura, talk to me a little bit about how people understood immunity in 1918. And did they have this notion that if they had recovered from the flu, they could go out and live without fear? And how that played into the propagation of the disease?
Did they have that notion? That's a good question. I mean, they had the notion, the idea that to prevent contagion spreading, you have to separate the sick and the healthy. That's very ancient, and that kind of predates germ theory, which was invented in the 19th century. So I think, for a very long time, we've known that when there's an outbreak of a dangerous contagious disease, you need to separate the healthy and the sick. And then I guess, yes, there was probably some idea of immunity from basic experience that, people who'd recovered didn't catch it again, but I'm not sure how well understood it was scientifically. Maybe David has an idea.
Once people knew what was going on, were they generally compliant? Did they follow the public health directives about wearing masks, for example. I've seen them wearing masks, avoiding large gatherings. In fact, weirdly, it's advice that is as relevant today as it was a century ago, and not that much more primitive.
No, I mean, we are very reliant on the same measures they had in 1918. As David said, we do have more treatments. We have antibiotics to treat those bacterial complications, but we don't have any really effective antiviral drugs, and we don't have a vaccine. So, you know, the kind of first line of defense is still the social distancing measures that they had in 1918. As for compliance, well, it's interesting. It really depends on where you're talking about in the world. First of all, you know, the way that public health measures were put in place was extremely patchy, and even where they were put in place in a kind of rigorous way, it might differ from the United States is a very good example, probably the best example of good public health campaigns, but it varied from state to state, from city to city. The length of time they were put in place varied. And you know, sometimes it was difficult for people to understand the rules. So maybe churches were open and shops were shut, or you know, there often didn't seem to be much logic to it. And I think that it's a little bit like what we're seeing today. Compliance might be good to begin with, and then maybe it falls off over time as people, you know, it gets in the way of people's lives and their ability to earn a living and so on. And also, you know, in 1918, there was a very clear sort of fall off in people's trust in doctors and in the scientific community, because they saw that they really had nothing with which to fight this scourge. And trust is absolutely critical. I'm sure David will reinforce this in putting in place public health campaigns of any kind, because it works best essentially if you have people comply voluntarily. And that means that they need to be well informed and that they need to be engaged and to have faith that you're doing things in their best interests. On the other hand, it was also a much more paternalistic time. So I think people were much readier to do what people in authority told them, at least to begin with. And it got tangled up with the idea of the war effort. So, you know, in the United States, for example, you were unpatriotic if you didn't wear your mask.
I saw yesterday an old photograph of San Francisco where they actually took the proceedings of the court outside into a park and had outdoor trials essentially for the duration. So in a way, the flu was public spectacle.
How? That's interesting. I mean, you know, one of the thoughts I've been having lately about why we don't remember pandemics is because they are less visual, in fact. The opposite, they're less of a public spectacle. We do have images of people dying on battlefields if you compare it to the war scenario. But people tend to die of diseases behind walls in their private spaces, and you know, we don't invade those spaces. We protect their dignity. So,
and also because they're terribly contagious, so there's a real disincentive to being there in the first place.
Of course. And so what we see tends to be pictures of people wearing masks or people carrying empty stretchers. The preparations, not the sort of thing itself.
Yeah.
And then the other thing, of course, is about mass gatherings. I think, you know, you could think of, I can give examples in the world where people fell back on organized religion. That was their main response. And so, you know, in Zamora in Spain and northern Spain, which I described in detail in my book, the bishop, who was a very charismatic character, basically said, we're not going to listen to the public health authorities, and ordered his flock into the churches. And they all went and they, you know, held masses and they had novenas and they prayed to be forgiven for their sins, which they thought they were being punished for. And Zamora had the highest death rate from the flu in Spain and one of the highest in Europe.
I'm going to go to another question now. This is from David Young, and once again, it's directed to you, David. What do you think of the notion that industrial farming is going to contribute to the jump in mutated viruses from animals to humans?
Well, we've already seen that industrial farming is important in epidemics and in pandemics. We have the avian influenza outbreak, which it started back in 1997 with an outbreak in Hong Kong, which was a virus that came from the animal kingdom into humans. It came probably from ducks who infected chickens in live animal markets, and then those chickens infected humans. Then this infection went on to become a pandemic in animals and in poultry rather. and in particular in industrialized poultry areas where they were raising chickens in factories. And so it became a great threat. And then gradually that threat was taken away by making sure that poultry were culled and that poultry weren't infected in many parts. But it did cause a threat to humans, and humans many times got infected from these industrialized farms. So, you know, humans today are demanding more protein in their diets in many places. When they get increased revenue or increased income, they demand more protein, demand more animal food. And as a result, we're seeing industrialized farming, which is very important in areas such as antimicrobial resistance, which is also an emerging infection. We see that infections in animals are become resistant, and then those organisms pass to humans, and humans have resistant infections.
So that's a bit of a scary prospect.
It's very frightening. And it shows what's important today in the world is to work in tandem. Human health, animal health, and the environment all working together rather than separately. Because these things are all so interrelated that if we don't work together, we're going to see more and more of these events occur.
Laura, we've talked about the Spanish flu in Europe and in context of the First World War. I'd like to ask you a little bit about how it traveled into what we'd now call the developing world. In those days, it was rather the exotic world from a Western point of view, and I'm thinking of the outbreak in what was then Persia, for example. How was it different as it traveled around in the non-European part of the Earth?
Well, to start with, Asia and Africa as continents bore the brunt of it. So those were the continents that experienced in general the highest death rates. North America, Australia, and Europe the lowest. And a lot of that was probably to do with poverty and in some cases lack of healthcare. Climate factors possibly contributed, cultural factors. Persia had a very high flu-related death rate, almost 25%. And Persia at the time was a failed state, essentially having been fought over in the so-called Great Game, and being a battleground for other nations. I've lost you, sorry. Oh, you're still there. So it hit a society in many ways on the kind of brink of anarchy, that it was at war, there was famine. And so it was something that was completely, that hit a completely susceptible population and that wasn't in any way channeled or controlled. There was no proper governance to put in place a public health campaign, even if Western medicine had been embraced there at the time. But I mean, the impact of the flu in every different society was different and was shaped by local context. And I think that's really important because we're seeing it again today in 2020 with COVID-19.
You spoke a little bit about how the Christian world, or some parts of the Christian world, especially Spain in your example, reacted to the virus and tried to make sense of the virus and tell people what to do. How did the Islamic world see it and try and cope with it?
So we have very little information from the Islamic world relative to the Christian, Judeo-Christian West. But I did include in my book a portrait of what happened in Mashhad in Iran, which is a shrine city in the northeast of that country and was probably the entry point for the flu there. And there it's quite interesting because I think first of all, it was a city that received the same population as its population again in pilgrims every year. So it had a huge number of people. It was, as I said, kind of on the verge of anarchy. There was famine, the harvest had failed, there were other diseases raging there. And the attitude of the shrine authorities, at least to begin with, was a relatively fatalistic one. But they did, they also put in place kind of, they tried to put in place quarantine. The idea was that if, you know, it's the ancient idea of quarantine again, that if you're on the outside, you shouldn't come, you should stay away. But if you're inside, you should, you know, stay put and try and separate the sick and the healthy. And then there wasn't much else they could do. There was prayer, and that's basically it. But that doesn't make it that much different from the Christian world.
No, it must have been interesting to you, or perhaps it certainly for me, the scenes in Qom in Iran at the beginning of the COVID-19 outbreak made me think immediately of Mashhad, and once again think how little more we have to offer, the Iranian authorities could offer today than they could 100 years ago, although the health of the people is certainly better now.
I mean, I think, one Spanish flu historian, Howard Phillips from South Africa, said to me that watching this particular pandemic unfold, he'd been struck by the sort of absence of an organized religious response. And I suppose we shouldn't be surprised by that in 2020. But on the other hand, you do see it every now and then, like in Qom. And I think, it's a reflection of obviously the beliefs of that society, the context of that society at the time, perhaps the level of trust in the secular authorities at that time, and also a reflection, I think, of people's fear.
We've got a question from Nishant Venewal, who says, the Spanish flu had an extraordinary impact in India, as you were saying, Laura, with almost a third of the total toll. And he's interested in knowing, why does it seem that this time round the developed world is facing a bigger toll than the developing world, than India in particular? David, do you want to take a run at that?
Yeah, well, it is quite interesting, and there are some hypotheses. For example, Africa. Africa is a very young continent. The median age is 19 years, which means that half the population is under 19 years of age. And we know that under 19 years of age, you have very mild infection and disease, and sometimes no signs and symptoms at all. So some of the hypotheses are that Africa, for example, is not seeing the same type of outbreak as in Europe because the dynamics are different. And it's true that the dynamics are very important in all of this, and there needs to be an epidemiological approach to dealing with it. In India, it is quite interesting that the elderly populations, and there are quite a few middle-class, very wealthy elderly populations who may have comorbidities like they do in Europe, yet for some reason it hasn't been occurring in those populations. Is this because India locked down rapidly when they had their first imports, or is it something else? And I don't think we can answer that yet, but it is quite interesting to see how India, how Africa have had different epidemiology, at least at present, and there are various hypotheses for Africa, as I said, whereas Latin America continues to have very difficult problems, as European countries have had. So it's just not clear yet. The verdict is still out, and as time goes on, we'll learn more.
You're counseling.
Patience,
you're
Elizabeth.
Counseling us patience again. Laura, we have a question for you from Owen Johnson, and he asks how the Spanish flu affected the outcome of World War I. Not necessarily who the victors and the losers were, but rather the fallout in geopolitics. And were there some completely unexpected results?
I mean, so there's been a lot of debate about this over the years. I think that it would be fair to say that there's a consensus amongst historians that it accelerated the end of the war, basically because there was a sort of purge of troops on both sides. They were just falling like flies in the trenches, and so there was no more, the war was just cooled off at some point, basically, no one left to fight. But it also had an impact that there's a sort of more minority view, which is more controversial, that it also influenced who won. Because it may have been in the German and Austrian trenches for longer, and in Germany and Austria in the civilian populations for longer than it was in the Western countries. And they also were hungrier because of the Allied blockade, which may have compromised their immune system. So there's a theory there, but it's as I said, controversial. And then the third wave of the pandemic, which struck Europe in the early months of 1919, had an impact on the Paris Peace Conference. Lots of the delegates there fell ill, and they included Woodrow Wilson, who obviously played a critical role in that conference because he was the sort of moderate presence, the counterbalance to the more vengeful European leaders. And he there are sort of eyewitness, and also his closest advisor, Colonel Edward House, fell ill with the flu at the same time.
At the same when they were at the conference?
In Paris, yeah.
Wow.
And but there are eyewitnesses who say that Wilson's personality changed a little bit that spring. He became less tolerant, less reflective, less willing to hear people out, and a bit more crotchety. And lots of neurologists have pored over this evidence in retrospect, which is a dangerous exercise. David's laughing. But because obviously you can't examine the patient. But there is a kind of view, fairly well supported, that he was probably experiencing mini strokes, transient ischemic attacks as a cause of the flu that spring. That those were responsible for changing his demeanor. And we know for sure that mini strokes predispose you to more serious strokes. And Woodrow Wilson suffered a very serious stroke that autumn when he was back in the States, which left him paralyzed down one side and prevented him really from persuading Congress to ratify the Treaty of Versailles and to join the League of Nations. So in that sense, you can argue that indirectly the flu had a very strong impact on the post-war world and a long shadow.
I believe I read, it was in your book, that the roots of the South African apartheid system lie in the Spanish.
Yeah, I mean, there's some evidence for that in the sense that, I mean, I think what pandemics do is that they can accelerate trends that are already in place. And I said earlier that, you know, it depends very much on the context that it falls into, that, you know, what impact it has in terms of social society and politics. But South Africa, there were already, you know, racial tensions there. There was already discussion about possibly legislating to segregate cities along color lines, for example, but nothing had been done in that direction. And during the pandemic, whites blamed blacks in South Africa for bringing the disease in, and blacks blamed whites. And blacks bore the brunt of it. There was a much higher death rate among the black population, partly because they were much poorer, partly because they had poor healthcare, many different complicated reasons. And it's in the early 20s that you see the first segregation laws passed. And of course, those remained in place for 60 years or more. So, so again, if indeed the flu accelerated that trend, it had a long impact.
It makes me wonder what's coming at us that we just don't see yet. David, what are you most worried about?
You know, I'm worried about the world overreacting, and not taking a rational approach. You know, we've seen countries lock down in Europe just spontaneously because they wanted to avoid the rush on their hospitals. And they had no exit strategy in mind. They just impulsively locked down. Whereas countries in Asia and other parts of the world continued with standard outbreak containment activities, continued to interrupt transmission from time to time by what they call circuit breakers, locking down a segment of the population if they found that they were at risk, and then unlocking afterwards. And they've had great success, and they will be able to sustain probably much easier than European countries, which locked down and now are really uncertain as to how to unlock, except perhaps for Germany and Switzerland and some of the other countries, which did continue those outbreak containment activities during the whole period of time that they were locked down.
You're touching on another question from Kaiser Khan, who asks both of you, Laura, historically, and David, in the present, which countries are the leading ones, or were the leading ones, the ones who best reacted to the respective pandemics? David, why don't you begin with now?
Okay, well, certainly the countries that had had SARS or MERS coronavirus outbreaks responded the best, because they were prepared. When they heard that there was a new outbreak occurring in China of a pulmonary disease, they reacted, and they started immediately controlling people coming in to make sure that they were under some type of surveillance, so that if they did develop symptoms, they could be isolated, and they began outbreak containment activities way before other countries did that. Then the first country in Europe to do that was actually Germany, which had an imported case, and they immediately began those activities and continued them. UK began those activities, but then it decided to go to what they called a mitigation strategy, basing this on their planning for influenza, thinking that this might be the way to move forward, and actually stopping containment activities for a time. And as a result, we saw that the UK government spent its efforts on testing people going into hospitals and making sure that they had adequate care, which is laudable. There's no right or wrong in this. It's just how it happened and how it unfolded. But I think there is legitimacy in saying countries should never have locked down without having an exit strategy in mind. And the exit strategy wasn't a vaccine, because a vaccine we don't know whether it will be available or not.
Laura, in 1918, did any countries have the wherewithal to do better than others in controlling the spread of the outbreak and indeed treating people who were ill?
Yeah, I mean, it was incredibly variable. I mean, if you stand right back and look at 1918, it looks pretty much like a pandemic that just followed its natural course. But there was variability. I mean, the United States probably was the best pupil in the class, but it was extremely variable even there. I mean, and that's reflected in the death rates. If you look at, I mean, New York had a death rate of 0.5%, but in Bristol Bay, Alaska, which I also wrote about in detail in my book, it was 40%. Alaska was not a US territory a state at the time, it was still a territory. But very little help was forthcoming from the federal government to Alaska at that time, and they were particularly vulnerable there for various reasons, including lack of historical exposure to the flu. Europe was pretty good too, again, pretty patchy. I mentioned the case of Zamora in Spain. There was often a tension between what the public health authorities wanted to impose, what the business community wanted, and the religious community was another element in that discussion. And I mean, I'd say it was probably only in Europe and North America, perhaps Australia, that the idea of the authorities intervening in your personal life for to protect the health of the community and a kind of public health campaign sense was fairly novel. In large parts of the world, that would have been an extraordinary idea. In New York, they were used to it, for example, because there'd been a 20-year campaign against TB, and you had to not spit, and if you spat, you were fined, and if you did it again, you went to prison. So that idea was relatively well accepted there. And then you have to remember also that it was wartime, and then after the end of the war, Reconstruction time. And it was also a time when, the world was probably at its peak of colonialization. And honestly, the European powers, the provision they made for the healthcare of the indigenous population in their colonies was poor, to say the least. That's one of the reasons why India had such a bad case. If you think about somewhere like Russia, it was in the grip of a civil war. Public health campaigns were way down people's list of priorities. Australia did a relatively good job, a very good job to start with. It had the advantage of being an island, if a big one, and seeing that lethal second wave of the flu approach across space and time in the first part of, or the middle of 1918, the authorities put in place a maritime quarantine, and that kept out the second wave. Unfortunately, they lifted it too soon, and they let in the third wave in the early months of 1919, and 12,000 Australians died in that. But it would have been much worse, of course, if they'd let in the second wave.
That sounds like news we can use.
A learning point.
So you mentioned some factors that contributed to the severity of the disease in 1918, the colonial administration, war, nutrition, famine, and so on. I was really struck this morning to open the FT and see that according to their statistical analysis, which is using more than normal deaths figures as opposed to the figures the government publishes on number of new cases, that it looks as if the UK leads the world in deaths per capita due to COVID-19. The world. Now, David, how can that be? What are the variables that might make that true?
The deaths during an outbreak are deaths due to the disease itself, clearly, and COVID is a very lethal disease for certain segments of the population. The dynamics of that are that elderly care hostels, where elderly people are kept in care, have been greatly susceptible, and they've been people who have become ill, unfortunately, and many of them have died. But in addition, there's a lack of access to health facilities at the same time in the UK during this outbreak, because GPs are telling their patients to stay at home. We'll help you by telephone, we'll help you in other ways than coming to a health facility. And maybe that also has caused additional mortality in the United Kingdom, which is COVID related, but not COVID caused. And so what's happening is that we're seeing that the inequalities and the difficulties in health care, in accessing health facilities, especially for those who are least able to make it to a health facility, might be causing an increase in deaths outside the hospital due to diseases that could have been managed better in a hospital, and they may not have died. So it's just beginning to be understood why there's such a high death rate in the UK, and other countries will now begin to look and see if they might have the same as well. We know in outbreaks in Africa, for example, in the West African Ebola outbreak, there were more children who died from malaria and measles than died from Ebola because they couldn't access primary health care where they could get treated for malaria, or they couldn't access the vaccine system because it had collapsed. So we're seeing the same type of events occurring in these countries, and that will be the excess mortality due to COVID. So COVID caused its own mortality, and in addition, an excess of mortality, which is related but not directly caused by the virus. So we'll see as time goes on, patience, Elizabeth, we'll see as time goes on why the UK has such a high level, and it may be that other countries find they have the same. I know Sweden is finding that as well.
Yes, could it be other things like demographic? You mentioned the youth of Africa. Could it be that we've got old people, that old people live in certain conditions, that could it be a nutrition thing? I mean, are there all kinds of variables that really need to be studied?
Yes, there are all kinds of variables. And let's go to Italy, for example, when they had this major outbreak early on in the spread into Europe. They had an outbreak which affected the elderly. Well, the population dynamics in Italy are such that the young many times live in the same household as their parents and grandparents. That's a known fact. And so when young people came back from skiing or from events where they became infected, they took it into the household, and the elderly were the ones who got seriously ill. And so that dynamic is becoming clear in Italy. In Germany, that's the entire opposite. Young people came back from skiing, but they don't have this same habit of the elderly living in the same households as the younger. And as a result, the dynamic was different. So many, many different things are important in all this. And we'll begin to understand them as time goes on, especially with the historians such as Laura, who will be dissecting this greatly to understand what really happened socially and historically.
You know that they say that a pandemic kills in three ways: the disease kills, the disruption to the healthcare system kills, and the disruption to the economy kills. I think it's really, I mean, I don't know what David would say about this. It's damning, perhaps, in the UK case that we built those Nightingale hospitals. They weren't needed, but you're saying that people were not getting access to health. So they weren't somehow getting the care that they needed, although it was there and those things were standing empty.
That's right. It's the tragedy of many outbreaks. The health system is occupied with those who are in the pandemic itself, and the others are left many times without the care they need. And this clearly, and I like your trilogy of those three causes because they all are important. And after this pandemic, we will see greater distance between those who have it and those who don't. It's clear that the less fortunate will continue to be less fortunate and possibly have been set back even more. This is in all countries, not just in the UK.
Elizabeth, there was a very interesting study, just because as I think has become clear, there are many factors that shape each country's experience. But there was a study from England published after the 2009 flu pandemic, which showed that the death rate from the flu was 3 times higher in the poorest fifth of the population than it was in the richest fifth of the population. So the socioeconomic effect that we saw in 1918 is still very real, and we're seeing it again today, obviously in COVID-19 with some of the I mean, there's an ethnic dimension to it too, as well, as we've seen in America and in the UK. So that's just one of the aspects that's going to be dissected by historians.
Mm-hmm, mm-hmm. Actually, there's a question that's relevant to that from Andrea Huber. She says, is there anything to indicate whether Spanish flu affected certain groups of the population more than others? And I think she may be specifically referring to skin color. Let me go on. So COVID-19 affects poor populations more, maybe unsurprisingly, but there's an indication, for example, that African Americans have a higher death rate. Why is that if it's not just poverty? And maybe you'd like to pick it up, Laura, and discuss that in a historical context.
Yeah, I think there's a little bit of data on that from 1918, but not very much to suggest that they were perhaps more vulnerable. Partly that was to do with discrimination and poverty, as you say, but there may have been genetic factors as well. There may have been factors to do with social and cultural and behavioral factors that shaped their historic exposure to the disease and therefore shaped vulnerability that way. I don't think we know too much about that. And this pandemic, you know, if it has a silver lining, at least it presents us with the opportunity to study those kinds of things now that we have better tools. But for example, again, in New York, which was in the grip of a wave of immigration at that time, it was definitely the immigrants who were the hardest hit. The hardest hit of all was the Italians. They were the sort of newest, fastest growing and poorest immigrants to New York at that time, and they scored the highest death rate from the flu. They were often living, for example, in tenements with 10 to a room. Another problem, apart from poverty, long hours, malnourishment, and poor access to healthcare, was that they often didn't speak English. So public health messages just didn't get to them. And that perhaps it might be also a problem in immigrant communities today as well.
Mm-hmm. David, do you want to address that? And I think that it's specifically the effect of COVID-19 on the African American community.
Elizabeth, there are a lot of studies right now going on to try to understand if there is a genetic factor involved. And it's important that they be able to separate this genetic factor from other causes of difficult and serious disease, such as comorbidities, diabetes, and other diseases, which might affect, in general, populations that are neglected by the health system. We know that it's very difficult for many public health systems to provide equitable messaging to all different populations, and they fail many times in doing that. And so maybe the prevention of these comorbidities has been less effective in populations which are also those populations which are African American in the US or others. There are many, many possible causes: genetic, comorbidities, just general neglect of these populations, and stigmatization many times of these populations away from those. Yet these are the people who are doing the most in the healthcare system in many countries, including the UK, and they're the ones that are most susceptible to getting infected, most at risk of getting infected, because they're in those conditions. So that's also an important factor to weigh in all of this, as to understand why certain groups of people are more susceptible to serious illness than others.
The person who asked that question wanted to ask it live, and I'm so sorry. I should have come to you, and I didn't realize you were waiting. So apologies, but I hope that you were satisfied with the answer. We're running out of time here, so I'm going to get quickly to a couple of other questions. One for you, Laura. This is from Anonymous. What are the parallels between the kind of PPE that was in use in 1918 and what we see today? I guess, have there been any improvements?
I mean, PPE in 1918, I think it was probably masks. Obviously, they had a good understanding of hygiene already, so it was, you know, the application of the principles of hygiene to their in the normal process of the work. I don't think they had anything particularly to protect them. And they had carbolic soap if they were lucky. Things were also short because of the war. So no, PP, we're doing much better on that these days, where it's available and not in short.
And you talk in the book quite a lot about aspirin, and I was fascinated to know that aspirin overdose was sort of an unfortunate byproduct of getting medical care for flu. How did that happen?
Well, I mean, I think in terms of pharmacology, it really was a very primitive era. I mean, there was no such thing as clinical trials, really. Certainly nothing of the kind of thing we see today, randomized, controlled, blinded trials, nothing like that. Sometimes they were tested in a few people. And there was no real understanding of what doses make a medicine, turn a medicine into a poison. And so it's not that surprising to understand that doctors who were faced with these people who were turning blue in the face, bleeding from their noses and mouths and dying, all around them, that they were trying to do their best to care for these people with limited weapons in their armory. And one of the key things they had was aspirin, the so-called wonder drug, which does actually, when properly used, reduce inflammatory responses. But they often gave too much of it in their attempts to cure their patients, and that can aggravate an inflammatory response, and so it often made the situation worse. And interestingly, they also used quinine, though there was no evidence that quinine, which is an anti-malarial drug, related interestingly to hydroxychloroquine. No evidence at all that it works for flu, but they tried it anyway, and they often overdosed their patients with that, producing horrible symptoms like tinnitus, affecting people's color vision. Very unpleasant side effects.
David, I think I'll save the last question for you, and it's a tough one. It's a personal one. It comes from Alexander Stewart, and he says, "I'm 75 and in as good health as my age would allow. I don't want to spend my declining years living a half-life, or I might say a living death. Should I be allowed to get back to what passed for normal last year, or would that be me being selfish?"
Well, for the time being, no. For the time being, we don't understand enough about what this virus will do in the next few months to say just give up all pretense of trying to protect yourself. But we do know how to protect ourselves, and that is to make sure that we physically distance. And that's not difficult to do in many situations. In others, it is. We have to learn how to do that. We have to learn how to protect ourselves and protect others as the basis of all of this. Protecting ourselves, we need to physically distance, stay away from crowds of people. When we go to a park, stay within our immediate circle of friends and don't go closer to other groups. And at the same time, if we're sick, we need to wear a mask to protect others. And so, if we're wearing a mask in a closed area, like a car in the tube, that's not to protect ourselves, that's to protect others. And others should also be wearing them at the same time. So to get back to normal, we have to just be sure that the population understands how they can contribute to this. And we all need to pay attention and make sure that we don't choose unwisely to go to an event or a place where we might not be able to physically distance. So we have to learn to live with this. I would say that we will learn how to do that. And I'm very positive that in the future, we'll either be living with this in the right way, or we'll have seen it disappear or go somewhere else. So I think
I'm saying to Alexander, it doesn't have to be a living death. It can be a modified form of a perfectly enjoyable life.
Absolutely. You said it better than I did, Elizabeth. And Laura might want to add something as well.
Laura?
Yeah, I was just thinking that here in Paris, this is my very unscientific take on walking around the city, but people under 40 don't seem to be wearing their masks very much. And so I think, that the thing has to be collective, and we have to think about how to protect the vulnerable populations while affording them as much liberty as possible, Alexander, and people of a certain age, since they're the most vulnerable. And that means that everybody we have to think of this as a collective. Even if young people are not so vulnerable themselves, they should be wearing their masks.
And if we do that, we can actually head off a second wave, right, David? That's in response to Robert Miles here, who's just tucked in a question.
Well, number one, we don't know if there will be a second wave. And if there is a second wave, we need to make sure that our governments have begun already to do the activities that they need to be doing in identifying where disease is occurring, getting out there and isolating patients and tracing contacts, testing those contacts if they become sick, getting them isolated, and doing their part in making sure that the outbreaks don't spread into a second wave, because you can prevent second waves. Asia has presented the first wave. Countries in Asia have presented an increase in cases by just doing simple outbreak containment measures and wise circuit breakers, lockdowns when necessary, unlocking when they could, and letting people get on with their lives. So I think we need to really understand that there doesn't need to be a second wave if there's destined to be one, that if our governments are doing what they need to do, if we're doing what we need to do, protecting ourselves, protecting others, that second wave doesn't need to occur.
Thank you both. I want to say to Hilary Brifa, who's just asked about 1918 and food access, we've run out of time, but Laura talks about that in her book, and I can't recommend it highly enough. Laura Spinney's Pale Rider. Also, James Craig Gray has just written in to say, but I want to hug my grandchildren. And I guess you would say to him, David, but you can. You just have to be.
You just have to see where your grandchildren were. And if they've been isolated like you've been, then certainly you should hug them.
Yeah. I know somebody who's seeing his grandchildren today for the first time since the lockdown. So we're getting there. We're getting there.
We're getting there.
Look, thank you so very much, David. It's been a pleasure to welcome you back to the Frontline Events panel. And Laura, such a joy to have you with us. And once again, what a lovely book. Thank you. I so enjoyed it. I will also take the opportunity to remind you that the events sessions are going to move to the evening in a few weeks. So watch the website. And I hope to see you, or if not see you, at least know that you're there listening and sending in such excellent questions next week at the same time. So from me, everybody at the Frontline Club, thank you and goodbye.